Well, hello and welcome to Cancer in Context. Today we have two guests, and I'll allow them to start by introducing themselves. Dan?
Hi, I'm Dan Hartman. I am a member of Morgan Health, which is a unit within JPMorgan that focuses on driving innovation in employer-sponsored healthcare. I co-lead the investment team as a part of that effort.
And Dr. Zafar.
Hello. My name is Yousuf Zafar. I'm the Chief Medical Officer at AccessHope, and I am a practicing medical oncologist.
So, for today's opening theme, we have accountability, cost, and clinical excellence in cancer care. Yusuf, I'd love to start with you thinking about when we think about cancer care today, decisions are becoming more complex and often more expensive, but accountability doesn't really feel well defined. How do you see accountability currently distributed between oncologists, health plans, and employers and other payers?
So I'll tell you, I see this every week that I'm in clinic, where I'm also in clinic with brand new oncology trainees. So these are doctors who are, just new to the practice of oncology. They're called fellows. And without a doubt, these new oncologists believe the accountability falls squarely with them, as they should. And as we all do as physicians, when we have a patient in front of us, we are responsible for making sure they get the best care possible, but only if it were so simple, right? Where what we see today is that in many cases, the clinical decision is not simply doctor wants to do something, enters the order and then it happens. There are steps along that way. And that's where some of that accountability might be impacted, right? Whether or not the treatment requires prior authorization or requires that it be run through some form of utilization management, all of which is designed to get the right care to the right patient. But the alignment doesn't often fit there. And I think that's where, from a clinical perspective, we start to see some friction around that clinical decision-making process to see how do we get what a particular clinician believes to be the right care. And I'd very carefully use those words because I think that belief part is something we should definitely talk about, what that means. Believes what to get that right care to the right patient at the right time.
Part of this too is, you know, when we talk about accountability, I do feel like in the vast majority of cases, everyone has the patients wants to do their best by the patient. I think the reality is behind the scenes at least on the financial side of things, like everyone's revenue is someone else's cost. And so how does that play out over time on the financial side of things? And how do we define accountability there? And how do we proportion kind of the spend across this in ways that's fair and effective and efficient and also geared towards, the best outcomes for the patients and their families. So yeah.
Do you have any examples of how financial incentives, Dan, on any side shape decision making, even if it's unintentional, but things you're seeing systemically? Or Yusuf, maybe there's a clinical example of that when you're talking about those friction points where we really see this at an administration of care level.
Yeah. I mean, when we talk about it internally, we generally talk about either what are positive financial incentives and what are negative financial incentives or disincentives. And I think it's probably not totally enlightening for those who are like in the oncology space we'd day to day, but on the positive financial incentives, one of the biggest ones is the buy and bill system. It creates a landscape where the majority of oncology practice economics revolve around drug margins rather than total value. I mean, in some instances, and it's hard to, always sweep with a brave brush, but the up to 80% of a practice economics can be driven by this system. So one of the key things I think we'll get into later is like, how do you shift that prescribing behavior towards more cost-effective biosimilars, therapeutic alternatives? Like that is one of the main incentives you have to get over. I think on the negative incentive or disincentive sides, what we think about is there's an absence of incentives for anyone to address the gaps in care between appointments that can lead to, you know, we think about cost of lease, like leading to overuse of acute care, ED, inpatient admits, things like that. So I don't know. That's how I've tried and bucket it those are two big ones. I don't know if you see anything different, Yusuf, but
Yeah, That makes so much sense, Dan. And I really like your framing of these sort of positive negative disincentives. I'd also add to both. So from a negative disincentive perspective, and there's very little incentive, or at least sufficient incentive, to prevent cancer, right? And I think if you're talking about I remember when I was sort of getting my training in health economics and health outcomes research, this question that we got asked repeatedly was, if you had $1 to spend, where would it be, in that cancer care continuum? And it's in prevention, right? That's where you have the biggest impact. On the other side, I would, again, Dan, completely agree with you in terms of buy and bill and how it can be at least seen as a perverse incentive. There's another one that I think is really important to think about, and that is the cost to patients. In many cases, can disincentivize what is the right care for the patient. And that's because now more and more physicians are starting to ask patients about their ability to afford treatment, as they should. And as we see, high deductible plans in many cases becoming the norm as opposed to the exception, as we see more cost shifting towards patients, more and more we're seeing that financial harm to patients impacting the kind and the quality of care that they receive as well.
That makes a lot of sense, Yusuf, because even as you're saying, and I was hearing Dan talk about, one incentive can even push to acute care, that can have a huge patient burden as well, not just a systemic burden. And so that kind of gets us to the misconception, and that's the punch of our conversation today. Is cost control inherently at odds with clinical excellence? Thinking about all the stakeholders we've discussed to date, there's a common perception that managing costs means compromising on care. In your perspective, either of you, I think maybe Yusuf, you had started talking about that patient experience as well. When do cost and quality align? When do they conflict? When is that kind of heartburn that they feel that they can't do what they're setting out to?
Yeah, I think we have to start with an assumption and a baseline that cancer care is expensive, and for the foreseeable future, it's only going to get more expensive, right? Seems like almost every drug that enters the market is, if it's more effective, it is also more expensive than the drug in the same class, prior to it.
Yeah.
This sort of step up pricing that we've been seeing for quite some time now. And so it's very clear to see that, there doesn't seem to be a bending of that cost curve when it comes to how expensive cancer is today, and what that cost care is going to cost tomorrow. And so then what does that mean to quality of care? Well, if the drugs are getting approved today are better than the drugs yesterday, but also more expensive, you see the problem here. And I really wonder if the answer comes into not so much what can we do today to control costs? What can we do today to decrease utilization? Because if you decrease utilization in oncology, more often than not, you're going to impact the patient and their outcome. I wonder if the appropriate lens here is really to think about it as not so much how do we reduce utilization, but how can we optimize utilization? And that means, coming back to putting the onus on the clinician to say, follow the evidence, right? Follow what we know is the best care for the patient. Because, I firmly believe this, when you give the patient the right treatment, their outcomes are going to be better and their healthcare utilization will be less. So what does that mean? That's a reduction in total cost of care down the road.
Have either of you seen examples where more expensive care did not lead to better outcomes?
Yeah, I suppose that if you're thinking about just the whole kind of total cost of care across the patient experience, like I think of, again, in broad numbers, say, across the total cost of care for one cancer patient, call it 60% is of that spend is in the drug, 20% is in, call it, emergency department utilization, inpatient admits, much of which could be potentially avoidable. And then the last 20% is in things like, imaging, E&M visits, et cetera. So I think through more expensive care defined as like the total cost of care for treating this patient, like there is it is more expensive when you don't have that sort of wraparound care, the things that might keep the preventable visits, in this particularly acute care setting, like from happening. So that's how I think of like the expenses across that total cost of care continuum, not just in kind of a narrow specific lane.
I think it's a really important point, Dan, because if you look at what's happened in value-based care and oncology over the past decade, right? I think we started by saying, all right, let's impact what we know we can impact, and that's acute care utilization, hospitalization, VD visits. Let's just deal with that because I don't think we can impact drug prices. Where today it's kind of evolved to the point of, okay, maybe it's just and prior auth, and then we can do some wraparound for acute care utilization. I don't think that's the answer either. And I feel like we could do so much more to, yes, absolutely continue on, you said it best, Dan, right? How do we help the patient when they're in between clinic visits? Right? Because that's when their need is greatest, and that's where their utilization can be really high if we don't pay attention to them at that point. And let's focus on getting the right treatment in terms of anti-cancer therapy to the patient to make sure that it's evidence-based so that they have the best chance at cancer control, which is another means to, I think, decrease healthcare utilization.
Part of the framing too, when people say cost containment, in the current system, like the prevalent view or mental model that comes to their mind is the adversarial relationship of just Like it's the stick, it's the effectively some sort of administrator getting in the middle between that patient and provider relationship. I think there, Yusuf, to your point, like there are ways to think about cost containment that are far beyond that, and frankly, in the better interest of the patient. So it doesn't inherently have to be, but I think the way we commonly think about it, like, is it can be at odds.
Agree. And I think we're stitching together here that I'm hearing from both of you is when there are high stakes, high cost decisions being made, there's a way to drive accountability across clinicians, plans, employers. Yusuf, you've spoken a lot about evidence-based. Dan, you've talked about focus, patient experience, and kind of following through that thread of what has been proven effective. So let's move from theory to practice. These decisions happen every day, often under pressure. We hear about the weight on oncologists' shoulders today, and with real consequences. So, what does shared accountability look like in action? And Dan, yes, we are not talking about putting a buffer between folks that nobody wants on either side, but we're talking about really shared systems that can work and sustain kind of going forward. And what role should stakeholders play?
This is such a fascinating discussion because I think it moves very quickly from things like, plan design and cost sharing and value-based care right into things like clinical education and AI. And that's very much because I think one of the first steps that we can take to start right sizing how much we're spending on cancer care is by educating our clinicians better and giving them the resources that they need to deliver the right care at the right time. The challenge is that cancer care today is evolving so rapidly. Last year, so in 2025, there were over 50 new oncology drugs, indications, and biosimilars approved. I don't understand how anybody can keep up with that pace of knowledge. And yet, we can very easily sit back and say, well, just follow the evidence, right? Do the right thing for the patient, that'll save you money. But you can see when you sort of look at those two statistics together of how expensive cancer is, and yet how many new, interventions are being approved every year. We need to find a better way of making sure that oncologists today know what the right treatment is for their patient. And I'll tell you, that's pretty challenging to do.
I can imagine. I can barely tell what's the right lunch to make for my kids each day versus understanding. And that is the challenge, right? Because time is also an axis in these decisions. We don't have time to be academic, run up the flagpole of what could be. They have to be made in real time at the time that a patient needs it. and their needs change over time. So I think you started a nice dialogue, Yousuf, on systems and tools, and maybe it even branches out to partnerships, could help ensure the right decision is made, not just the fastest, the easiest, or the one that's the most easy process to communicate. Dan, I'm not sure if you've seen any examples of tools or partnerships or systems that have worked really well to help align stakeholders across this, but would certainly be interested in your thoughts, if not examples, what it takes to get there.
Yeah. I mean, in terms of solutions in the market, again, just to give it a general framework, there's like kind of three buckets we generally see in the space. Like one is to our earlier conversation of just optimizing the kind of current processes. So it's like you're going to do prior auth, but you can do it faster. Like that is something like we are not particularly interested in, like from a mission focused investor perspective. So I kind of put them on side. The other two being democratizing access to best in class care. To Yusuf's point, like this is a incredibly dynamic, fast moving, and from an employer perspective, making sure that our members, if they're going to their community oncologist, that community oncologist has the resources and can provide the latest and greatest care to our members is important. So that's like bucket two, which is very important to us. And then three is finding the solutions that can align incentives amongst the different stakeholders to actually drive towards the best, most efficient, effective care for our members. So in that third bucket, it's kind of where we live. The problem is, it's like people ask like who should be accountable, and in my view, it's like, well, every stakeholder in the system has a role to play. Otherwise, why are they stakeholder in the system? Like, you
Yep.
know, Yusuf, if you're kind of young and hungry and eager beaver, like new docs come in, really feel accountable. That's amazing, but they can't do it in a vacuum. And I wonder, like, as they get into practice, start realizing they don't have the tools and resources around them to actually have the accountability that they want. So there are solutions out there that are starting to adopt that and provide some of those services, but it takes time. Like the idea that there's a silver bullet we can flip on overnight and do this, I think is unrealistic in a way. For example, and we talked earlier about the kind of buy and bill incentives. There are solutions out there that are trying to find ways to partner with practices so that they can share in those savings to ensure that practice economics don't perform worse financially when they're choosing a higher value drug intervention. But that requires a lot of groundwork to get there. And I think scaling those things out market by market, practice by practice, just will take time.
Well, I mean, Nicola, when you started, I think you said maybe we're not going to solve the healthcare problem today, but I think Dan just did. What Dan said was we need to align incentives. That's it. End of story. I think we're done. I think that's the biggest challenge in where costs and quality misalign.
Well, in the spirit of kind of bringing to that silver bullet conclusion, which, it's not the goal. The goal is to really raise awareness of where are the tensions and what are things we can do. I won't say what's your silver bullet solution. I won't ask you the magic wand question. I will ask, what is one shift, whether cultural, clinical, operational, from a payment perspective, but what is just one shift that could move us a step forward in accountability?
Particularly when it comes to cancer. I think one thing that we can do that will help with accountability and I think help with that alignment of cost and quality is to look at cancer costs through a different lens. And that is through the lens of not how can we limit utilization, but how can we right size utilization? So, how can we make sure that the treatment the patient is getting is actually aligned with the evidence? Because we know that when we see that alignment with evidence, we see better outcomes. We without cancer drugs actually reducing in cost by order or orders of magnitude, as those intervention costs continue to rise, in my mind, that's where the solution is let's actually align how we're thinking about utilization with quality and care, because when we impact those outcomes, we will also impact cost in a sort of total cost of care approach.
So I'll take like the kind of, as you might expect from like the investment guy, kind of the market perspective, which is I think dem- taking a more proactive and demanding approach on behalf of employers, managed care companies, taxpayers, whoever's footing the bill ultimately, and recognizing that there are alternatives to the status quo. And although imperfect or not scaled, those options are being funded. They are out there, and proactively looking for them and pushing, whether it's your current carrier or someone else, to some intermediary to help bring that into your population is a cultural shift that I think we've seen more and more, even over the last 5-10 years, particularly amongst the employer population. That that proactive approach to challenging the current status quo and trying new solutions in the best interest of the patients is the cultural shift I think is ongoing, but I'd love to see accelerate. So
Thank you. So it sounds like cost and quality aren't at odds, but actually needed to do these proactive shifts and this alignment that we've identified today. And that, my friends, is a wrap on our myth busting of cost and quality today. And love the discussion around the tension that exists. Dan and Yusuf would welcome any kind of closing thoughts you have.
I appreciate the time for what it's worth, and I think what you guys are doing at Access Hope, as someone who sits on the outside and isn't living it day to day, I'm glad there are people out there like you guys who are trying to make a difference like every day and bring those things to market. So I appreciate it.
Thanks.
And I gotta say the same for you, Dan. Keep funding the stuff that's making a difference, right? What's innovative out there, what's, impacting patient care in new ways, go after it.